Okay, welcome to our pit crew CPR agency training. Our pit crew is different than the rest of the county because we run two-person companies, right? So you could be first in an ambulance, which has a two-person crew. You could be first to an engine, which has a two-person crew as well. So we need to reduce our CPR down to, at least our initial interventions, down to a two-person crew. What we know about CPR and cardiac arrest management is it's all about execution. The ALP study, which the results of which haven't been published yet, but what we are going to learn is it's less important what we do in terms of ALS, but how we do it. So execution, execution, execution. We need to keep all of our time on the chest. In terms of the algorithm for medics, it's gotten much easier. PAA systole is down to epi, single drug. Shockable rhythms, very simple to manage now. Essentially epi and amiodarone. Amiodarone is contraindicated, lidocaine. And then if you get all the way through the algorithm, then you get down to MAG. So we have done everything we can to simplify the paramedic part of cardiac arrest management. However, we need to emphasize the BLS component. Seattle championed this with the BLS owns the code, and that has been demonstrated through research, through data, to be effective. So the point of this training is to execute perfectly. So I'm going to go through the steps of our initial two-person management. This is not the only way to do it. This is a way to do it. If you don't have a plan, use this plan until you develop your own. So the whole idea is you come across cardiac arrest, you're a two-person crew, you're a medic and an ID tech, because that's what we run on our rigs. First thing you do is you walk in and you see if the patient actually has a pulse, and while you're doing that, you ask if you should be resuscitating the patient. Do they have a DNR? Do they have a pulse form? There is no pulse, so you immediately instruct your EMT to start doing compressions. He starts doing compressions. As soon as compressions are started, we turn on the monitor, right? So this is ground zero time. Right now we have an arrival time of our apparatus to the scene, right? And now in some cases, our apparatus has arrived 200 yards before we actually get to the scene with our AVL, right? But we need to be able to document when we start doing interventions, and our first intervention on the cardiac arrest is compressions, right? So as soon as compressions are started, you turn on the monitor. We're going to run everything on this monitor. We're going to put all of our interventions into this monitor, and it will all be marched out in real time and print out in your code summary when you complete the call and write your chart. Okay, so the first thing you do is you turn the monitor on as soon as he starts doing compressions. Our number one priority is CPR and cardiac arrest. So what do we need for CPR? Well, help a brother out, allow him to do good compressions by turning on the CPR button, which is the next thing you do after you turn the monitor on. This is set for 100 times a minute. I can't make it 110, which is absolutely optimal, but that's okay. If we do 100 times a minute consistently throughout the entire code, that will suffice. And then we need to put it in paddles mode. Why? Because we need to record the compressions that your partner is doing. So to put it in paddles mode, hit lead, spin the dial to the bottom, push the wheel. Now remember, you used to be able to spin this and it would beep, and then you push this. When you have this metronome on, there are no other sounds coming from the monitor, right? You can only speak one language at a time. So when you go to charge, it's a shockable, well, when you go to analyze and you charge before you analyze, you will not hear the charging sound. The monitor will look the same. You'll still see the bar going up, but you will not hear that traditional brrrr. CPR is going to override all of that. Okay, so right now, my first priority is CPR, and I'm facilitating my partner. I have the monitor turned on. I've time-stamped when we have started intervening in this cardiac arrest. We've put the CPR button out to help him do good CPR, and we are recording the CPR that he's doing cardiopulmonary resuscitation, our next step is the pulmonary part, right? We have to ensure that this patient has an open airway, an open conduit to 21% atmospheric air, right? That means an OPA. First thing you do after you set this monitor up is you go and you put an OPA in. So on this mannequin, we're not going to use a full-size OPA because we do use this for innovation. I don't want to tear up the inside of the mouth, so we're just going to use a little one. Anyone remember what the true sizing of an OPA is?
Ear to corner of the mouth.
That's right, ear to corner of the mouth or angle of the jaw to midline of the mouth. So if you think about it, it's the same distance, ear to the corner or angle of the jaw to center of the mouth. It's just moved, just displaced a little bit, right? So I don't care how you put the OPA in, there's lots of ways to do that too. I traditionally do the bass fishing technique, which is you give them the bass hook and you slide it in, and this is a small one, so it's not going to fit in there really well. Now you have an open conduit from the lungs to 21% atmospheric air, right? And you have a ventilator. The ventilator is the person doing compressions. He's causing positive and negative intrathoracic pressure, which is going to bring that air in and dispel the air, right? But while I'm here, I'm also going to throw on a nasal cannula. And understand the patient's dead, right? So you don't have to hook this up perfectly. You just have to get the nares, the nair pieces in the nares, because you want to fill the oral pharynx with 100% oxygen that the compressor can then take in and blow off with positive and negative pressure. So you hook this up, turn it on. 8 is fine. It's going to sound a bit like a jet engine, but really all you're trying to do is get 100% oxygen to the oral pharynx, right? For now, this is CPR. CPR is done. We are not bagging this patient. We are letting the compressor do the ventilations for us. And for our first priority, CPR, that is good. We've got a lot of other stuff to do. Then our second priority is electricity, right? So I'm going to come over here, and in this patient we have these hardwired in, but normally you would pull out the patches, hook it up to the intervention cable. The end of this is the exact same fitting as patches would be. So you plug this in. And then while I am here and at the monitor, I'm also going to put on an O2 sat. One of the things that we have found with our agency is that we have an abysmal track record of putting on an O2 sat until we get ROSC. We need to put the O2 sat on at the beginning. It will stay there till the end. Ideally, you would use the adhesive one, the portable adhesive one, but for right now, for quick and easy, put this on. You can replace that later, right? I am done with this station at this point. I'm ready for electricity because I have the patches on. Now I go to our third priority, which is drugs, right? Which means vascular access. And for cardiac arrest, that means an IO. So, pull out our IO kit, and we're going to go over this specifically as an individual skill because everybody needs to know how to do an IO, medics and IV techs. Not a lot of medics are doing IOs anymore. Usually that gets relegated to IV techs, but sometimes we run double medic cards, right? Which means one of the medics is going to be doing an IO. And if you show up with a single medic and your partner's doing compressions, that means you, the medic, are going to be doing the IO. Right now, in this house, everybody's home, right? So we're going to send the engine and the medic unit at the same time. This would be a great thing for the IV tech to do. So we'll talk about that when the time comes. This training one, I have a real IO kit that's Velcro together so we can reuse it. You want to use proper length needle, hook it up, and we'll talk about the skills of this at a separate time. But one thing you need to know about this is that you can interrupt the IO process at any time, right? So even if you had sunk this into the bone, remove this. Even if you had sunk this into the bone, and all of a sudden your compressor says 180, you can disconnect this and walk away. And then you go analyze the rhythm, shock or dump the shock, and then you can come back and address it, right? Even if you had removed the obturator, so that this is essentially an open butt now, right? You can still walk away from this. There is no internal pressure from the medullary cavity of the bone to expel anything like there is when you start an IV into a vein, right? You can walk away from this, come back later, hook up the extension set, flush it, and be on your and administer drugs. So that's an important thing to remember. Once you start the IO, you are not necessarily locked into completing the IO before you go up and analyze and administer electricity if it's indicated. Okay, so that is essentially our initial pit crew plan. It's very easy to run a code with 2 people until additional resources arrive. And the goal is, when additional resources arrive, wherever you are in this plan, you assign these stations to appropriate personnel, and then the medic rolls out and runs the monitor and governs the call, right? So that the medic who's in charge of this patient is the one that analyzes every rhythm, that decides what drugs are going to be given to this patient. Essentially, this is his responsibility. Historically, we run very open calls. Well, we're kind of shutting that down a little bit. Open calls is a good thing. I'm a big advocate of that. But in terms of cardiac arrest, which is all about execution, we need to shut that down a little bit and have one person be in charge of it. And when the lead medic gets focused in on a task, he loses sight of the global picture. So we're trying to move away from that. So after these initial interventions and resources arrive, I want the lead medic to roll out and run the monitor, record all the interventions done. And we'll talk about that a little bit as well. That is the basic plan. There are other ways to do this. WID, for instance, in terms of the order of this, WID likes to do it by kit. Instead of kind of jumping between the Airway and the life pack. I'm going to turn this off. So his plan is, rather than following, and the reason I kind of devised this is, for me it's thematic, right? First priority CPR, right? So everything that I do in my initial is attached to making sure good CPR is done, right? So CPR includes compressions being done and making sure that there's ventilation. And to have ventilation in this case, you've already got a pump driving the ventilation. It's to make sure that there is an open airway and there's oxygen in the oral pharynx, right? WID likes to do it by kit, so he's not doing multiple things out of multiple kits. So he will come in here and do everything out of the life pack that he is going to do initially, and then move to the Airway and do everything that he's going to do out of the Airway initially, and then he's going to go do the IO. That works too. The point is, you have to have a plan, and you have to be able to execute that plan well. I don't care what the plan is. If you don't have a plan, follow my plan or follow WID's plan until you develop your own style, and you can ensure that all of these things get done. The nice thing about having all of these things that need to be done is that when you do get additional resources, they can walk in, look at the patient, and they have an expectation of what it should look like, and if they see any abscences, then they can correct those at that time. If you walk in and say, oh, the pulse ox isn't on because the initial medic forgot to do that, they can make sure that gets on. Okay, let's go back to the Airway really quick. In terms of Airway, our priorities, our litany of priorities first thing is an OPA. Why? Because the OPA ensures that there's a conduit to 21% room air to the lungs, right? CPR doesn't do us any good if we're not circulating oxygen. Second is OPA and a nasal cannula, just like this. And if you don't have the resources, that's as far as we're going to get initially. Third is OPA, nasal cannula, and then a BVM on top of that. The BVM is not going to be hooked up to oxygen, right? Because we already have oxygen going to the oral pharynx. We're just going to put it on top, and we're going to breathe for them with the BVM. Do not overbag. We're talking about once every 6 seconds, right? That gives them 10 breaths a minute. Understand the metabolic demand of a dead guy is very low. This is not a linebacker. This is a dead guy lying on the floor, right? You do not need to overbag these patients. And then, following that is intubation. We may or may not intubate this patient. It depends on the course of the call. If you have a medic here while he's bagging, he should also be preparing to intubate, because if we need a definitive airway, we will intubate first. The only time we use an I-gel in our system is as a rescue airway. So when you cannot physically intubate the patient, that's when you go to the I-gel and sink it in. And once that I-gel is in place and it's effective, and you get good ventilation and you get good in-tidal, you leave that in place. So once you drop that I-gel, we're kind of committed to the I-gel. So in our system, that's a rescue airway. VFD's gone to throwing in an I-gel every time, initially. That's the first thing they do. Understand that an I-gel is a glorified OPA. It is not a definitive airway, right? So an OPA has these channels in the side of it, and you introduce air here, and it goes down the channels and ostensibly goes into the airway, right? An I-gel, that's just a closed loop. So when you blow air into an I-gel, it goes down a channel and introduces that air right across in the glottic opening, which is maybe a little better than this, but it essentially does the same thing. It also has this LMA-like seal around it, which does not seal any gastric acid from coming out. It keeps large particles, pieces of steak, that sort of thing from getting in there. However, gastric acid is very caustic to the lung tissue and is a source of downstream pneumonias and all of the other things that keep these patients, should we get them back, from ever leaving the hospital. So, do not confuse an I-gel with the definitive airway. It's essentially a coarse product blocker, but gastric acid's still going to go around and everything's going to go around it. So really, it's an OPA. Think of it as an OPA. So we're going to put the OPA in, and then if we need a definitive airway, and why would we need a definitive airway? Because with prolonged CPR, they get a bunch of stomach contents in there, they're gurgling, there's crap in here that you cannot keep out with just an initial suctioning. Yes, we're going to need to intubate that patient. If we get ROSC early and they start spontaneous respirations, and we discontinue CPR and their airway is clear, we may never intubate that patient. We've had lots of these that we have never intubated. Okay, so the other thing that I want people to know is whenever they come in, Slocumb comes in as the second crew, he gets here, he knows exactly where to pick up. He gets assigned to the airway, he looks at the airway, and he's like, oh, there's an OPA in, there's a nasal cannula on there, and oxygen's flowing. Then my next step is to pick up a bag and bag once every 6 seconds on top of that. If there was no nasal cannula, he would come in and say, oh, there's an OPA in there, I need to put a nasal cannula on there, and then I need to bag on top of that. Same with when we do our isolated IO skills. I want people to know that whatever they walk in, and there's the needle has been inserted, the obturator's been removed, it's open, that they need to flush the extension set, and then or fill the extension set and then flush the IO, and they can pick up right where that initial medic left off and complete the process. So for today, we're going to break up in terms of crews. Everyone's going to come in We're going to follow the exact process I did just now. If you forget something, we'll pack it up, go back to the door, start it over. The whole idea is that this is about execution. We're trying to develop muscle memory and habits so that everyone else can walk into a scene and know what has or hasn't been done and can seamlessly fold into it. Okay, let's talk about time stamping on these monitors a little bit. So once resources arrived and the medic that's responsible for this patient rolls out and runs the monitor and governs the scene, I'll turn this on again. We need to timestamp all of our interventions. Now, B Shift had a code that went 46 minutes the other day, and they, I guess a couple weeks ago now, they were in a shockable rhythm the entire time. They went through the entire algorithm, which included epi, which included amiodarone, which included mag, which included Narcan. Could not get the patient out of a shockable rhythm. It was a viable patient. It was a 39-year-old witnessed arrest, not witnessed by EMS, but witnessed by other workers on scene. They had started CPR. After 20 minutes or so, they called the doc, and the doc said, yeah, bring him in. So they did compressions all the way through transport, which is unusual for us and for our county. They got to the hospital. They were still in a shockable rhythm. This is after 15 shocks at this point. Hospital continued to work them, shocked them another 9 times, and ended up calling the patient in a shockable rhythm. No idea what the story behind that was. That's a very unusual code for us, right? But the interesting thing is they use this metronome throughout the entire call, and after 46 minutes, their average was 101 compressions a minute for the entire code. And all of those compressions were recorded on the monitor, which we don't often see when we transport. It's very difficult to do good compressions while you're transporting. CPR button works. And then imagine trying to write that chart, right? It's really easy when you do 2 interventions and then you get something back. Well, they recorded like 14 or 15 of their interventions on here. When they print out their code summary, it was essentially a walkthrough of the call in real time, right? So right now, to timestamp an event, hit the event button, and this is the first screen you get. I've modified this since ALPS, right? So the first page you get is all of our cardiac arrest drugs. I'm gonna have to keep playing with this because otherwise it's gonna time out. But you see on here, epi's the first thing, amidarone's the next one, lidocaine, mag sulfate, dopamine, naloxone, innovation, and bicarb. These are all of our cardiac arrest drugs, right? May not get to all of them, but they are all on the first page. I put bicarb on there. We do not routinely give bicarb to cardiac arrest patients, although there are some protocol-driven indications for that. But every once in a while, you will call the physician at Southwest who graduated from medical school in 1968 who says, yeah, give him an amp of bicarb and work him for 5 more minutes. So I threw bicarb on there. We also get some other oddities every now and then. Recently, somebody, or last year, a doc said, yeah, I give him an amp of calcium and work him for 5 more minutes. And the medic said, calcium? And they're like, yeah, calcium. He's like, Ca++ calcium, right? He's like, yeah, give him an amp of calcium, call me back in 5 minutes. So they did, patient remained dead. But at that point, you do what the doc tells you, right? He is your immediate medical control in that moment. If we have the ability to do what they ask us, we do what they ask us. So that's the danger of calling the doc. Sometimes you open up a Pandora's box. But at any rate, that's why this is on the first one. When you timestamp something, you indelibly put it at the moment into the data set at the moment that you timestamp it, right? So if you administer epi, timestamp it when you administer it or immediately after. If you forget and 2-3 minutes later you think, oh shit, I forgot to timestamp epi, I'll timestamp it now. It will record the data as if you did it in that moment, right? Which isn't when you actually did it. In that case, do not timestamp that event, right? Because it's going to give you bad data. So I also added, I let it time out on me. I also added one other category called cancel last. So if you screw up your timestamping and you immediately go back in here and hit cancel last, you will know that the timestamp immediately before is not accurate or is wrong. This doesn't change the data, right? The data is the data. This just gives you a marker that the last timestamp was inaccurate. Does that make sense? I have also included another page, if you go down to more, and these are our other cardiac drugs, because cardiac calls are what's primarily run on the monitor. And I have aspirin on here, which is not that important to timestamp, but it is in the chest pain cardiac algorithm. Nitro is on here, adenosine is on here. Now in terms of timestamping adenosine, do it immediately before or after. Adenosine needs to be administered properly, so don't improperly administer adenosine to get it timestamped. Cardizem is on here, atropine is on here. The reason we want these on here is because we are going to do an intervention that is going to have an effect on the ECG, right? So if you put atropine on there in real time, you can, when you run your code summary, you can march out changes to the ECG that are a direct result of the drug that you administered, right? I also threw on here glucose, because frequently we give glucose, and albuterol, because on respiratory calls, in terms of the monitor recording your SATs and your in title, it's useful to know when you actually started a treatment that's going to affect those O2 SATs and those in title, right? Does that make sense? That you would want to know, or later it would be useful to know, when you actually started treatment and what recorded values came immediately after the start of that treatment. So essentially, those are the two screens. The first screen is all your cardiac arrest drugs. The second screen is other cardiac drugs, including albuterol, because that's the useful thing to know. When we look at another report writing software, we're going to be looking at one where all of these will download to that software system with the times that they're time-stamped. So this is kind of a segue for us into that sort of, this is the poor man's version of a competent reporting system. So we're using the tools that we have available to us now. Does that make sense? All right, so now it's just practice. We're going to break into two-person crews and run through this a whole bunch of times, and we'll also go through the proper steps for setting up an IO.
Is it acceptable to use the generic under the meds, or do you want to avoid that and use the actual meds that are listed?
If the med isn't listed, use generic.
Okay.
I would prefer you actually put the med that you used, because when you go back and there are 8 generics on there, you're like, one of these is innovation, one of these is epi, one of these is amiodarone. Did I give 2 or 3 epis before I got to amiodarone? You know what I mean? It's
Sure.
just less precise, but it is more helpful than what we're doing now, which is not helpful at all. So yeah, if you can, use the actual ones. And the whole idea about having the medic roll out and run the monitor is that they can actually input this stuff accurately in real time without delaying any interventions, which are being done by the other personnel on the scene. Does that make sense?
Was the innovation on one of the lists?
Yeah, so the innovation is on the initial one.
Okay.
So it goes epi, amiodarone, lidocaine, mag, sulfate, dopamine, naloxone, innovation, and then bicarb, and then cancel last. That's the first screen. All right. Well, let's get to it.